Real Talk with a doctor with over 40 years experience, Dr. Cheryl Woodson, taking care of elderly patients, otherwise known as geriatric patients. She shares tips and suggestions and tells caregivers why it is important for them to avoid burnout. But we begin by asking her, how did she get started?
And then Risa Levizo Mori, who was a Robert Wood Johnson Fellow. She was actually CEO of the Robert Wood Johnson Foundation. She was Chief of Geriatrics at the University of Pennsylvania. She was at Temple as a junior faculty member. And she showed me what geriatrics is. She was the first geriatrician I'd ever seen. And I also had a Latino gentleman who was in his late 70s, and he had been taking care of his grandchildren, allowing his daughter and son-in-law to stay in the workforce. And at some point, his back started to hurt him so badly that he couldn't pick up his grandchildren, couldn't stand and wash clothes and things. And he had an abnormality on his x-ray of his spine. And I couldn't get anybody to biopsy it because of the date he came on the planet. And he was from Puerto Rico, so it's possible it was Pott's disease, could have been tuberculosis. If I treated it with radiation like a tumor, he was going to die. And if I treated it with antibiotics like tuberculosis, he was going to die. I needed to know what it was. I couldn't get anybody to biopsy him. Not ortho, not neurosurgery, not interventional radiologist, because of the day he came on the planet, just because he was 7.
Oh, because of his age. That's what you're saying.
Right. They said he was too old, but this man was stabilizing a family, letting 2 adults be in the workforce and keeping all of them out of poverty because he was doing the childcare. That didn't matter to anybody. And when I decided I needed to teach geriatrics, Risa showed me that I needed to be a geriatrician, that older adults are not just like younger adults any more than children are like adults. Pediatrics is not general medicine, and neither is geriatrics. But I realized I needed to teach when that happened. Also, on my service, I could keep 20-some-year-old white male medical students and residents from calling an 80-some-year-old Black woman by her first name. But I couldn't make anybody else do that off of my service. So that's what's geriatrics.
So, is there an age that you have to be in order to be a geriatric patient?
Supposedly, that age is somewhere in the 60s. 65 arbitrarily, because that's what Medicare says. That's when Medicare says you're old. But geriatrics is more about function, really. Now, some geriatrics programs will not see anybody under 60. And I remember I did an NPR interview once where they asked me whether 60 was the new 40. And I said, well, 40 is the new 70 for some people. It's about function. Can you handle your business to keep yourself safe and active on the planet?
Right.
And we have basic activities of daily living. It's how you interact with yourself just to be. Can you eat? Can you dress? Can you, those kinds of things. But then there's instrumental activities of daily living where you interact with the planet. Like, do you have the ability to figure out what you need, get the resources you need to do it, and do it fast enough to hurt yourself, not to avoid hurting yourself or somebody else? That, to me, is what function is. And like, I'm 68 years old. Like you said, I have a second-degree black belt. I walk 3.9 miles in 65 minutes, 4 days a week. And I just started Krav Maga lessons. I don't need a geriatrician. I don't have functional deficits. I do need somebody who understands that my physiology is different from a 40-year-old, though. And I think general internists need to learn that. But I don't need a 3-hour assessment and an hour visit every time I see the doc. I don't have 17,000 medications. I don't have 50,000 different comorbidities. And I don't have a caregiver who's too stressed to really figure out how to help me. So that's what geriatrics is for. It's for people who are at risk of nursing home placement, who have complex comorbidities, who are also strangled by the social determinants of health, and have caregivers who are stressed. That is what geriatrics is for.
So you know that because you have the advantage of being a physician. But if I'm 65 years old, newly retired, am I being proactive if I say I need a consult with a geriatrician?
Absolutely. A consult is perfectly reasonable. What I would hope is that whoever you talk to would say, this is what we need to look at, this is what we need to look for, and not just automatically put you into an hour slot when you don't need one. But
Right.
that is an assessment that needs to be done. This is why geriatrics assessment is so critical. It helps figure out who needs what. And it's risk stratification. You can't possibly give all of those resources to everybody who happened to be born in a
Yes.
certain year, but it is risk stratification.
All right. So let's talk a little bit about geriatrics. It's a relatively new field.
From the 70s, if you think 70s is new in this country.
And did it come about paralleling the baby boomers
It
aging?
came out because of Vietnam and World War II vets. The VA created geriatrics in this country. The
Really?
Veterans Administration, yes, ma'am. And even today, some of the most effective and prestigious and well-funded research programs are affiliated with the VA. Like I went to UCLA and there were 2 VAs in our fellowship program. Um, and I think that's where it started.
My understanding is that it has its popularity has faded over time. That
I'm not
there
sure because I'm not sure we ever had it.
really
We
uh,
ever had.
my understanding is that it's a complex field because there are lots of different aspects to getting older. And you kind of touched on it. It's the functional, it's the mental component. There's all these factors that come into play. So it can be complex.
Some major physiologic differences between healthy older adults and younger older adults that you need to understand if you're going to prescribe medications, if you're going to look at medication side effects. Um, so it's functional and cognitive and physiologic, and there are age-related diseases. And one of the things that makes aging such a problem in this country, because of ageism, the bias against people who are aging, or the expectation that people who are aging are not competent or have purposeful or useful,
Yes.
is we focus on age-related illnesses. Like dementia is age-related. Now, it may be if we get to our physiologic limit as a species of 120 years that everybody will have it, but that is not true now. Over the age of 65 in this country, maybe 15% of the people have dementia of any kind, but that means 85% of them don't.
Right. The way it's portrayed, you would think that was reversed, that
Well,
85% do develop dementia.
yeah, but 15% of the fastest growing population in this country is no small thing. I'm not saying we shouldn't focus on it. I'm
That's
not saying, but I have
let's
a
let's
97-year-old aunt taught 3 line dancing classes a week before the pandemic.
wow.
That's how it has to be.
So let's circle back to something you've actually said this twice. You said the physiology of a 40-year-old is not the same as a 60-year-old. What's the difference?
One of the problems is a difference in total body water versus total body fat. Because as you age, you lose lean muscle mass, you lose tissue, right? So you lose water because most of the water is intracellular. It's not actually in the blood vessels, it's intracellular. So your total body water decreases. So when they say this is a toxic level of a water soluble medication, that's based on 40-year-old people who have a certain amount of water. You have that same amount of chemical in a smaller amount of water, which means it's going to be toxic for you at a number that won't seem toxic for other people.
Mm-hmm.
We need to teach that. Older people do not make fever. You can have
Make
positive blood.
fever.
No, they'll be totally afebrile, no fever at all, have blood cultures that are positive, because the T cells, as you age, do not make as many leukocytes, these lymphokines, these hormones that attract other inflammatory cells to help you fight it. And it also mediates fever. So you can have an older adult with positive blood cultures who will not make fever. So you have to look at changes in cognition, changes in function.
Mm.
Older people may not have the same kind of thirst mechanism that a younger person will have. So when it's hot out, you've got to really encourage them to eat and drink because they won't feel thirsty and will end up dehydrated. Doesn't happen with younger people in the same way. So these are just basic physiologic principles that may not apply to every single old person you see, but you've got to have your radar up. For example, digoxin, digitalis, is a heart medication that is water soluble. What is a normal digitalis level for a 40-year-old may actually be toxic in an 80-year-old because they have less water, but nobody changed the concentration. Right. Those quote unquote normal values are out there, but they were based on younger people.
Right. And it's conceivable that someone could have been started on this medication at an earlier age, and it's just not been titrated down.
Right.
As they got older.
The same thing is with alcohol. People may be able to tolerate a certain amount of alcohol at 40 that they can't tolerate at 70. And we just need to know what the physiologic possibilities are so that we can be open to protecting people from unnecessary illnesses and understanding how illnesses may present differently in older people than they do in younger people. For example, blood infections.
Who's supposed to know this? I mean,
we're supposed to teach it in medical schools, but we don't.
Oh,
geriatrics is mandatory in, I don't know of any medical school where it's mandatory. You may have a 4-week elective, but I don't know any medical school where it is mandatory to teach geriatrics.
Okay. And that's back to you have fewer young doctors wanting to go into the field, supposedly because it can be a complex, complicated specialty. But
I don't think.
I didn't hear you.
That's not why they don't choose it.
Why don't they choose it?
Anesthesiology can be complicated. Neurosurgery is very complicated. I don't think that's why they don't do it. In my book, To Survive Caregiving, A Daughter's Experience, A Doctor's Advice, there is a section on why it's like this. It's not just teaching people how to do it, like the 5 keys to caregiver survival, the level of care prescription. It's not just that. It's why is it like this in the first place? Because unless you know why it's broken, you can't even think about fixing it. And on page 206, there is a graphic that shows you why I think this is. It's a cycle, 4-part cycle. First of all, there are very few geriatrics faculty, senior geriatrics faculty, very few. Students in medical school and residency choose their careers not just based on their interests, but based on mentors that they admire. So you don't have any geriatricians, you don't know anything about that. You don't learn anything about it. But let's say you do choose to go into geriatrics. Geriatrics is the only subspecialty where you come into fellowship training with no information about the basic organ you are working with. When a cardiology fellow starts cardiology, they know what a heart is. They've learned about that since second year of medical school. They don't know how to do a cath, but they know when somebody needs one. Since geriatrics is not taught in medical schools and there aren't a lot of senior geriatrics faculty, geriatrics fellows come in with one hand tied behind their back. They know nothing about dementia. They know nothing about function. They don't know anything about interdisciplinary teams. They don't know anything about psychosocial assessments. They don't know the physiology. They don't know the pharmacology. So they have to learn the basics while they're learning how to be academicians and researchers and publish and administrators all at the same time. So you're coming out with your hands behind your back. Then, because there's no geriatrics faculty, if somebody wants you to come as faculty, you come into a higher position than you would in cardiology. You come in as chief. Somebody offered me chief of geriatrics right after my fellowship.
Mm,
That doesn't cardiologist. So you have people in a one-person shop at a high level with no resources
mm,
and no ability to, like, I didn't have any problems. I UCLA was the best geriatrics fellowship in the country, which is why I went there. I did not have any LA vibe. I went there for, if it had been in Idaho, I'd have gone. They
mm,
taught us everything. We learned how to be medical directors of long-term care facilities. We learned how to write. We learned how to teach. They taught us everything. They taught us how to run a department.
mm-hmm,
So I had no problems thinking that I would have a problem administering this department, but my CV was not as thick as the chief of cardiology because I just came out of fellowship.
mm-hmm,
So who's the dean going to listen to if I need another faculty line?
mm,
So I wasn't stupid enough to do that because chief of nothing is nothing. A lot of
mm-hmm,
people get all excited about being chief of geriatrics somewhere. We have more clinical responsibility, more teaching responsibility, more administrative responsibility than any other subspecialty level faculty member in a medical school.
and
And we have senior mentors. So we don't know how to write, how to publish, how to get grants. We don't know any of that. And the cycle goes around because there's few of us, but when people see us, the students see us, they see us overworked and unrespected by the other subspecialties. So
mm-hmm,
they theatrics and it goes around and around.
mm-hmm, mm-hmm. And I've also heard that it's not as lucrative.
Oh no, the demographics do not drive the dollars. The fact that older people are the fastest growing population in this country, Medicare pays 40 cents on the dollar, and that hasn't changed in years. And they don't pay for what you really have to do. Like they will pay me to order an MRI every time there's a quote unquote change in mental status, but they won't pay me very much. And they just started paying us at all for sitting down and telling families this is dementia. Another MRI is not going to help you. This is what we have to do. So Medicare pays to do things to people, not for people.
Mm.
And as long as Medicare is your primary source of revenue, it's very difficult.
So what did you do? You were smart enough to say, I'm not going to become a chair of a department.
Right. And what I did, this is another thing, Risa, I said, I will come as deputy if you bring Risa as chair. But again, this is because John Beck, who was then a major faculty member, director of the geriatrics program at UCLA, looked at my proposal
Mm-hmm.
and helped say, in year one, with this amount of resources, I can do a consultation center. In 2 years, with this number of faculty, I can do da 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 da, just to build it up over 5 years. And they responded by meeting my salary demand, which wasn't really the point. So I, instead of doing that, became director of the fellowship program at the University of Chicago.
Okay,
And that started my academic career.
cool. All right. That's fascinating, but let's change the focus a little bit from the geriatric patient to that person's caregiver,
Yes.
because we find that women in particular become the caregivers of their parents or older relatives, and that can be very challenging. Can you speak a little about that?
Well, that's primarily what To Survive Caregiving is about. What I get is it's a daughter's experience, a doctor's advice, because in the middle of all of this, I diagnosed my mother with Alzheimer's disease.
Hmm.
She was driving, she was managing her money. She just was not the woman who raised me. The first time she asked permission to interfere in my life is when I had the neuropsych testing, you know. And so I had a lot of fight with my family because they didn't believe me initially. And in year seven of a 10-year caregiving
Can I
relationship.
stop you for a second? What's the difference between Alzheimer's and dementia?
Dementia is the overarching category of brain dysfunction that is progressive and irreversible. It is a terminal illness. People die of dementia. Alzheimer's is one form of dementia, and there are several. There's dementias from stroke, dementia associated with HIV and other viral infections. There are frontotemporal dementias that don't start with memory loss at all. It's like apples, oranges, and pears are all fruit.
Is the treatment different depending on what type of dementia a person may have?
Yes,
Okay.
yes, it is.
Yeah.
And the care plan may be different. For example, frontotemporal dementias are atypical. And if you recall, the actor Bruce Willis had problems with speaking, and then they realized he had primary progressive aphasia, which is a type of frontotemporal dementia that does not begin with memory loss at all.
Hmm.
So you really have to get in there and diagnose and wait, because sometimes you don't see it the first evaluation. You don't see everything the first evaluation. Again, where geriatrics is important, information is important. There is a 30-point scale called the Mini Mental Status Examination that is a screening tool. It is not a diagnostic tool at all. Simple screening tool. One of the tasks is to draw intersecting pentagrams, and that gets you 1 point. If you lose that, you lose 1 point. And I had a patient come in who got a 29 out of 30. But what he couldn't do was draw those pentagrams, and he'd been an electrical engineer. He should have been able to draw that. So you have to know not just what the results of tests are supposed to show, but what those results mean.
Gotcha.
And that's taught well either.
All right. So back to the caregiver. In your situation, you were seeing changes in your mom.
Yes, I was. And this could have happened in high school. It could have happened in college. It could have happened during my fellowship, during my residency, and it would have derailed my career. And while it was horrible, in the year 7 of 10 years of caregiving, my mother looked at me and said, "Do I know you? I thought I was going to die." But God waited until I was finished and came in my long suit. I can't be upset about that. If she would have dementia, who better than me? So I can't be upset about that. But many caregivers do not have that, of course, which is why I wrote To Survive Caregiving. It tells you exactly what you're looking for. And the 5 keys to caregiver survival tell you how to do it without killing yourself or the rest of your family. It's very, very
to be clear, this is a book or a course that you've developed.
Both, but it's a book. First edition came out in 2006. Mother died in 2003. And I had been giving little pieces of this in presentations. And after she passed, I said, "Oh, this is nuts. That's not what it is." I started from the beginning and wrote an actual book that came out in 2006 and did very well. I'm very proud because AARP listed it among the top 10 elder care books of 2012.
Fantastic.
Association put it on their preferred list. And then in 2000, during the pandemic, basically, I decided I wanted to do a second edition. And I only wanted to update statistics and add one more chapter. And that was another kind of widow. It's for people who are married to folks with dementia. They're not dead, but that's not your husband either. And I had a caregiver who didn't want to deny her husband physical intimacy, but felt like she was being raped every time because he wasn't her husband anymore.
Oh, that's hard.
Oh, yeah. And see, nobody talks about this stuff but me, because I'm a North Philadelphia colored woman with a Sagittarian mouth. I have to be real. I only know one way to do it, and it's coming straight up. So that was the only chapter I wanted to write. But as I wrote, I realized there were other things, questions people had asked me over 40 years that did not belong in a general overview of caregiving. So with the second edition, I published a companion book called The Doctor Is In, Answering Your Questions. Good. And there's a chapter on what do you do if mom gives all her money to Pookie and you don't have money to buy your medicine? What do you do? What if dad goes to the casinos every weekend and asks you to pay his rent every month when you've got 3 kids? And after 40 years of working with caregivers, I sort of had a clue. So both books have real caregiver stories that illustrate the problem. And yeah, I've changed the identifying information so you can't. Yes. Although these are caregivers from my practice who, and actually, in The Doctor Is In, I had a focus group. I fed them and told them what I was writing and asked them what I had missed. And I hadn't missed anything, but they took me so much deeper. And their wisdom was so amazing that I gave them their own chapter. I call them the care warriors. And Doctor is in ends with a chapter of what the care warriors tell you to do. These are the people who, for real, did
These
this.
are people that are actually taking care of their mother or husband.
Or who have.
And the reality of that lifestyle.
The reality and also how you survive it, because they did.
Right.
You know?
Because it is all consuming.
It can be. And I had a 58-year-old caregiver drop dead and leave two 80-year-old people here. And, people, I remember I was on another NPR interview where this neurobiologist or somebody talked about the T values and all this other stuff, the reason why caregivers. I said, no. That may be true. That may all be true, that there's this biochemical something with the immune system. But this caregiver knows to the last pill when her father's medicine needs to be refilled. She hasn't had a mammogram. She hasn't been to the doctor. She didn't know she was diabetic. So it looks like that heart attack came out of nowhere, but it didn't. So it is self-neglect in a lot of ways. So in 2015, my daughter had a very serious life-threatening illness, and I wrote these affirmations to keep her going and realized it applied to all women. So, Dear Lauren, Love Mom, 31 Days of Affirmations for my daughter, for myself, and for you, came out in 2021 to help people learn how to take care of themselves better. And to teach other people to take care of them, and to give ourselves the grace that we give other people. One of the major pieces of this book of Dear Lauren, Love Mom is an affirmation says, I will be kind to myself. And one of the questions is, if somebody told you what you just told me, would you call them any of the things you call yourself? Would they be lazy? Would they be stupid? Would they be weak? No. So why can't we give ourselves that same grace? And that's what that particular book is about.
Because it feels selfish.
Yeah.
Because
self-care, not selfish.
Yeah, it feels as though you're placing yourself above the other person and you're neglecting them. And then that looks bad, because society says
you're putting yourself above and you're neglecting them are not the same thing. One doesn't go into the other.
But there's only so much time in a day. So if I take time for me, that means that's less time to give to the person I'm taking care of.
And if you don't take time for you, you die. And then what happens to them? Up in the nursing home bed next to them. So what I tell people is, you take care of the finances and the house and the car and the doctor's appointments and the medicine and the food. You have to take care of the thing that makes all that possible. You have to take care of their caregiver.
Yeah.
It's not selfish. Now, you're not period at
Why
the end
is that so hard for people to get? Because I know women who are caregivers. I have been a caregiver. I know sometimes it almost feels like guilt if you're not doing. So,
and that's one of the first things that I say in To Survive Caregiving is, I am here to get rid of your guilt. That's what I'm here for. Because first of all, women are trained to keep other people comfortable. We are raised to keep other people comfortable and to be good girls and to have nobody be mad at us. And so it's part of the training. But as I said, I had a caregiver die and leave two people here. And I've said to families, okay, if you die, what's going to happen to this person? And they start thinking of all the things their other relatives will do to ameliorate that. And I say, okay, well, do you have to die for that to happen? Why do you have to die before that happens? You can hire help now. You can, look at other ways to get things done now. You're the quarterback. You are not the line staff. You have to make sure stuff happens. You do not have to do it all yourself, because you can't. And, you've heard about the sandwich generation, right? Between children and older adults. But the 21st century caregiver sandwich is a multi-level club. This is the first generation where women have been taking care of parents, grandparents, in-laws, other older adults, children,
Mhm.
grandchildren, and great grandchildren, all at the same time that they're working, trying to stay married, and trying to plan for their own golden years. Never happened before in American history. So you can
Interesting.
do it the way your mother did it. This ain't your mama's caregiving.
Mm.
And in the book and in my presentations, I have pictures of my great grandmother, my grandmother, my mother, me, and my daughter. And it tells you how many kids they had, how many daughters they had, what the daughters were doing. Were they working or not in the workforce? How old the grandchildren were. My great grandmother's grandchildren were 27 years old. My mother's grandchildren were 3 and 7, you
Mm.
know.
Mm.
I was working 60 hours a week. My grandmother was not working at all when she was taking care of my great grandmother. My grandmother lived downstairs from my great grandmother. My mother was in Philadelphia. I was in Chicago. My brother was in Haiti. It's a whole different thing today. So you can't judge yourself by past generation standards. And you can't let other people in that generation tell you what you need to be doing. There's a chapter in To Survive Caregiving that says show up or shut up.
Right. Because there's
They,
family dynamics too.
Mhm,
Usually
mhm.
there's one person that kind of gets the role of caregiver and everyone else gets to live their life.
Right. And it is either the oldest daughter, the youngest daughter, or if there is no daughter, it's the oldest son's wife. But
Wow.
that's why geriatricians and geriatric social workers and community or elder care organizations, we step in front of the caregiver. So it's the doctor said mom needs blah, blah, blah. And there's actually language in To Survive Caregiving that tells you exactly how to say this. Because you don't say show up or shut up, but you can say it so that you can still have Thanksgiving next year. I mean, I'm very specific language. This is what you say,
Cool.
and
That,
this is how you do it.
all right. So if there are caregivers, and I'm sure there are listening, tell us which one of your books would you recommend to get started with first?
The second edition of To Survive Caregiving, A Daughter's Experience, A Doctor's Advice, that came out in 2021. That's where you start.
That's the book. Okay. And that's
Start.
the one that has the chapter from the ones that were actual caregivers. That's it.
Every book that I write that's nonfiction is based in this is really what's going on.
Okay.
This
Okay.
this family challenged it, and these are how you manage those challenges. It's very, very practical.
Okay.
Very.
And if you're someone that's 65 and older, are there proactive steps that we can take for ourselves?
Yes. There's a chapter in The Doctor Is In that I wrote for Monique Carradine Kitchings, who's my coach. When she was 40, in her 40s, she was terrified because her parents were aging and she was an only child and she didn't know what to do. And I said, well, that's actually a good thing because you don't have anybody to argue. But I wrote a chapter called Prepared to Care. And it is for people who are afraid of caregiving and want to be ready for it. But it's also for people who want to make their caregiving easier on their kids.
Right.
This is what you have to do to set that up.
Right.
I think physically, the first thing you need to do is find a strong primary care relationship. If it's not a geriatrician, that's fine. You start with your primary care team and you work on your health and your fitness and your blood pressure and your diabetes and your stress levels and all of that. You also need not to be afraid to see a behavioral health counselor to help you manage whatever pain you are living with. And whether you're carrying it from before or whether it's still happening, those two things are the first steps: a physical primary care doc and then a behavioral health person. And many people of faith don't want to go to behavioral health. But one of my pastors, the Reverend Dr. Frank Thomas, said that counseling clarifies what you need to pray about. Not either or. It's not either or.
It's not either or.
No, and so you want somebody going over your medications to see that they're in the right doses for your condition now, not 10 years ago. Whether you need the same medications, whether you need less, whether you need more, whether you need different. Somebody needs to look at your care plan and tailor it, not just for you, but for the lifestyle you want. Docs need to stop thinking that we cure people, because we don't, and we never have. Our job is to use the science as we understand it to give people the best shot at the quality of life they want. That's what we're here for. So we give people information and we help them, make sure they have information to make the choices. And the choices also include what will happen if you don't do this. We got to be very clear that this is what happens. But the other thing we have to do, I think, falls are the number one cause of death in people who have Alzheimer's, hospitalizations and death. The fear of falling is even more disabling than falling itself. So getting yourself in physical shape not to fall is really important. I'm on the board of the National Council on Aging, and the National Council on Aging has an evidence-based fall prevention program that you can get involved in. They also have what's called the benefits checkup. It's a software program where you can put in your information and it will spit out every municipal, state, and federal program that you might qualify for income and housing and transportation and medication and jobs. That, it really tells you what's out there so you know how to get help.
I come across a number of people who have conditions, high blood pressure being the top one, that don't take their medications. And when you ask them about it, often they say they want to do something more holistic. They're going to take CMOS or they're going to do something.
If it works.
But my question to you, are there clear practices that help to either reverse, retard, delay, decline, like drinking so much water or exercising so often or certain types of food? Do you have those holistic type of treatments?
I think we know that. There's a lot of data coming out now that's trying to refute the whole cholesterol issue, and we're looking at that. But if you are interested in what so-called holistic practices, you need to see an integrative medicine physician. Allopaths don't learn that. Your traditional doc does not learn nutrition, doesn't learn any of that. Wish we did. But each major medical center has an integrative medicine program. The National Institutes of Health now has an area where they study these quote unquote holistic remedies and subject them to the same rigor that we do our pharmacology and everything. It's very important to find somebody who is trained in what it is you're thinking about. Your average doc doesn't know that, but integrative medicine physicians do. They are usually MDs or DOs and naturopaths. They're dually trained. Mm-hmm. And they understand the acupuncture and all of the red rice yeast and the cinnamon and the garlic and the other things that we might use. But what we know is that if your blood pressure is not 120/80, you're going to have a problem. And to me, that is the number you care about. You don't care about how many milligrams. You don't care about how many medicines. The number is 120/80. That's where you need to be. How low can you go and still be standing, decreases your cardiovascular risk. And for some people, they may have to run a little higher blood pressure because they can't stand up because of it. That's why you need a primary care team that's going to focus on you and what's for you individually.
All right. So what about people that say the doctor just doesn't take enough time with me, or I'm a Black person and I don't think they care? What is your response to how do I achieve that in a system that I think doesn't see me or doesn't support me?
Medicine today is a customer service industry. My mentor, Dr. James R. Webster from Northwestern, used to say, doctors don't have patients, patients have doctors. If you are not satisfied that your team hears you, takes time, that you don't feel they care, fire them and find somebody else. The other thing you have to understand, though, is that most doctors today are not in control of their practices. They're working for companies, so they can't control their schedule, how much time they see people, blah, blah, blah,
Absolutely.
which is why I went into solo private practice for 12 years. I got tired of that. But for you to get time with a physician, you may have to pay for it. Okay. You may have to find out from that practice whether they schedule family meetings or conference time. And you may have to pay for it because health insurance will not. And
Mm-hmm.
people get upset about having to pay for a doctor's time, but you pay your accountant, don't you? You pay your lawyer, you pay your plumber, right? And if you need a plumber, you don't yell down the drain. You make an appointment. So why would you sit in your mother's hospital room and wait for the doctor to walk by and just happen to talk to them? They're not going to have time for you then. So you have to call the practice and find out how this person does that and make an appointment. There's a whole chapter into Survive Caregiving called the Physician User's Manual. It tells you how to do this. You call the practice and you find out who manages prescriptions, who manages lab results. Because if you say, I want to talk to the doctor, that's never going to happen. And if you are in a nursing home or a hospital, you've not been to the doctor's office is still where you call to make that appointment, because the nurses in that facility don't know that my child has a parent teacher conference today. They don't know I'm not coming. My office manager knows that.
Mm-hmm.
Schedule. So even if you've never been in the doctor's office, that's where you call to find out how to set up an appointment in the nursing home, in the hospital, or in the office. Now, Thursday evening was my family caregiver night. And I would do conference call speakerphone and have everybody in the world there so that they hear it from me, not from their baby sister.
Wow.
I charged for those visits.
Wow.
Now, I needed more than 15 to 30 minutes, because if I can't explain a care plan in 15 minutes, I need to go back to medical school. Sometimes I went in tandem with a geriatric care manager from the community. So
Yeah.
I would medical stuff and then sit back while her name was Kitty Watson. I love Kitty.
Yes.
She's retired now. But she would put together the psychosocial and all the money and everything. And then if there were medical issues that helped determine those questions, I would come back in and answer those questions.
Got you.
And we did tag team. It was wonderful. And people paid me. They wrote checks because it was worth it to them.
Yes. Yes. So, which brings me to my other question. I can imagine people are saying, will you be my doctor?
Yes. And it's so wonderful. My God. I mean, I lived in the community that I worked in. I left Northwestern and left academics to come down to the South suburbs because I was in Homewood. My mother-in-law was sick. She was in Harvey, and I needed to be home. I needed not to drive 3 hours a day. And when I went into solo private practice, I was in Chicago Heights and I lived in Homewood. I could walk to my office. It was great. So I still see people in the grocery stores and, and I go to funerals when I hear about them still, because my patients took better care of me than I ever took of them. I mean, they made it possible for me to do what I did. When I came back from maternity leave with my daughter at Northwestern, there were packages to the
Oh,
sea.
that's sweet.
They are sweet. They're really wonderful. I wouldn't change a minute of it. There's not a minute that I would have done differently about how my career went. And I'm just so grateful to all the patients that allowed me to touch their families. I mean, that's just amazing. But I stopped clinical in 2012. I had one lawsuit in 40 years, one, and it broke my heart. I got sued by somebody I'd never seen in the whole 5 years I took care of his mother and his father. They sued me for $4.6 million when your malpractice only covers $3 million. You're on the hook for the rest of it. And they brought somebody from Boston to Chicago, paid them $65,000 to sit on the stand and say that I was negligent because I didn't do something that nobody does.
Mm.
People who testified for me, like the neurosurgeons and radiologists, they said, "Oh, nobody does that. We wouldn't. That's not what we would." She gave us what we needed. It took 4 years
Mm.
and 15 days, and I was on the stand 8 hours. And we won. That's not the point, though. It broke my heart. And I can't do it anymore. And I'm sorry if that makes me a weakling. That broke my heart. I couldn't do it. And the person who they sued me about is one of the caregivers in my book. He and I were really close. We were really good, so, and
That's
I'd never seen
heartbreaking. That's
it.
heartbreaking.
I had no malpractice cases at all until 2004. I graduated from medical school in 81. But between 2004 and 2008, I had four and a report to the regulatory commission because the statute of limitations had run out on malpractice. But that's when the market tanked, right? Between 2004 and 2008. That's when I started seeing those. One of them sued. It was a family of a patient that I hadn't seen in 8 months, that the family knew I wasn't going to be part. I didn't have staff privileges at the places they went. After a surgeon friend and I saved her from complications of a procedure that neither of us did. Mm-hmm. And so most of them didn't go anywhere. One of them, the report to the regulatory commission, I came back because I used to do taekwondo in the middle of the day just to keep from going nuts. So I'd go do a class and come back. And I came back, and this man is sitting in my office, in my waiting room with my patients. And he's demanding a chart and telling me that there's this action coming in. I pulled him back in the back and asked him. He wouldn't tell me the patient's name. He wouldn't tell me the issue. He told me the name, but wanted the chart. And I said, I'm not new at this, right? I know I don't have to give you my chart. You know that. And don't you ever come in here without an appointment again. And he said, well, I'm going to report you to the boss. I said, you do whatever you need to do. And I paid an attorney $800. I sent the chart to the attorney. The attorney went over it, and it came to nothing. But every time I renewed my license, every time I renewed staff privileges, they ask you, have you ever? And the answer is yes. It's not yes, and it was nonsense. It's always yes. And I can't do that anymore. I'm sorry. I wish I could.
Yeah. Wow. That's heartbreaking, but let me thank you for being so transparent. That has to be something difficult to talk about. But the net effect is, well, you had written this before, but you have a greater audience now. You have books. Yeah. You may not have as intimate a contact as you had in the past, but you're reaching more people with your books and all the other avenues that you share this information.
Thank you for saying that, but I'm a clinician. I'm a clinician. I mean, when I sit on these boards and all these people talk about research and scholarship, I go, I'm not a scholar, I'm a clinician, and we do research to help the clinicians. That's why we do this. When I was pregnant with my daughter, she was a month early, and I'm there walking around, and this old patient said, Dr. Woodson, that baby done dropped. You ain't gonna make it. That night I went into labor, and I called and said, I had a temp of 103 once, and I was working, and this old patient walked up to me and said, go home. I said, yes, ma'am. Wow. The desk, I don't know if you can see it. See my roll top desk back there?
Can't. It's out of focus.
It was made by one of my patients. He made it for me. The relationship that I had with patients, what they did for me. I mean, there's a lady, I love her to death. Her name is Sister Gooseby. And my manager used to schedule Sister Gooseby between people that I didn't like because I needed some Sister Gooseby time. It was the most wonderful relationship to have people trust you with stuff, to tell you stuff they don't tell their pastors. It's such a great honor.
Yeah. I don't think medicine is that way anymore. There is electronic medical records, there is AI, there's 10 minutes to get it done. I don't think the ability to sit down and actually talk with a patient exists anymore.
That may be, but I think that in the 80s, physicians gave up our responsibility when managed. I am a doctor. I am too cool. I can't deal with the money. And the people who were in charge were first the old head nurses. And if they had stayed in charge, this stuff would have made total sense. But they retired. And CFOs decided that anything that had an MD or an RN was a clinician. So they hired all these MD, MBAs who'd been on the floor 5 minutes. And then the senior physicians came back as utilization review people. But by that time, but when I stopped doing clinical, I became a medical director for managed care. And as I was doing these peer-to-peers where people call and ask you, try to talk you out of stuff, and they don't know how to do it, I found myself going, well, it was a blah, blah, right? You know? So I then switched and became a physician advisor to try to teach people how to do it. And I remember this one person was going off, somebody with a high school diploma would hand this intern or resident a chart saying, you have to do this peer-to-peer. The doctor should be deciding who needs a peer-to-peer.
Yeah.
And what I said to this person was, honey, if you don't sign it, they can't bill.
Yeah.
You have a lot more power than you think you do. And if this is a medical staff issue, the problem is the physicians don't like each other well enough to hang together. But if medical staff stood up and said, this is not how we're going to do this, who they going to get? Remember the right stuff?
Mm-hmm.
The astronauts, they ask, who you going to get to fly it? You know? Mm-hmm. But we don't accept our responsibility. It's our my name is on that chart. I had somebody want me to switch and say that somebody had one kind of infection rather than another kind of infection because they got more money for the other one. That's my license. That's my integrity. I'm not going to jail for you because you think you can make more money. I have been like that all the time. I used to send articles. You know, the standard of care is, and if you don't want to pay for it, it's your house, not mine. And I would just send the same letter the next week.
Yeah. I don't know if it's salvageable. I don't know if doctors training now have that desire for a relationship with their patients.
Yeah.
They could do it if they wanted to, but why would I want to? Right.
Learn it from faculty. And I was medical school faculty for 10 years. I'm not beating up anybody, but the people who teach clinical medicine, the clinic docs, are not people who love outpatient medicine. They're junior faculty, don't have enough grant money to buy themselves out of clinic time. And they've not been out of the tower. These are hospital-based clinics.
Yes.
They don't know what Catholic Charity does. They don't know how to call adult protective services. It's not part of the training. But it was part of my training as a geriatrician. And that's why I was able to continue to practice the way I was.
So tell us again before, I don't want to take up too much of your time. Woo. But no. I want you to share all of your information, your website, your books, so that if someone can't actually have you as their clinician, they can benefit from the wisdom that you have.
My website is very easy. It's drcherylwoodson.com, drcherylwoodson.com. It links to Amazon, my author's pages, so you get To Survive Caregiving, The Doctor Is In, Dear Lauren, Love Mom, which is the book about how to take care of yourself. And I did so many virtual book club discussions over that during the pandemic that people asked for a workbook. So there is a workbook to help facilitators run those programs in their churches or wherever they want. So those are the four. It's To Survive Caregiving, A Daughter's Experience, A Doctor's Advice. The Doctor Is In, answering your questions about how to survive caregiving. Dear Lauren, Love Mom, 31 Days of Affirmations for my daughter, for myself, and for you.
Yeah, I would imagine with Medicare renewal and all of that coming up, that's a perfect time that organizations and churches should just have seminars where they can talk about caregiving and dementia and all those type of things.
And November is National Caregiver Month. And it is also National Alzheimer's Awareness Month. And I am thinking about launching a podcast in November.
Oh, yeah. Or just courses where
last year that did, and I used to for November, I used to go to libraries and show films about dementias and talk to people, so I may be doing that again.
Yeah, because there is a need. There is a need, definitely for caregivers, because, like you said, never before in history have women primarily felt themselves in this crunch and finding a way through all of that. It would be.
And I just did a conference for the CDC's Women's Health, their celebration of their 40th anniversary of the Women's Health Division of CDC. And I'm going to be talking at the Age Guide seminar in Naperville on Wednesday about the face of financial insecurity in aging is female. Why it is that older women are at risk of more poverty. But the bigger thing is that during the pandemic, we learned that women as young as 18 are actively doing caregiving. And the biggest poverty cohort in this country is women 18 to 30. We didn't know that.
Or
So
the blossoming of or the concept of aging in place.
Mm-hmm.
We're going to keep mom out of the nursing home. We're going to allow her to age in place, and how that changes dynamics in the family. And also this home health industry that's developed as an answer to, we can provide that in-home care. There is so much to this.
Yeah, there's not an answer because home health agencies are failing left, right, and center because of the financial issues. And aging in place is not the job of the caregiver. It's the job of the older person, him or herself. You need to start that at 40, figuring out how you are going to I have it set up so that all my daughter has to do is write checks. Okay. I don't want her to move me into her house because I've seen elder care ruin marriages and teenagers and a whole lot of that. I'm real clear about that with them. They need to make sure that I'm healthy, that I'm happy and safe. They are not supposed to. I gave them their life, their future. They don't have to give me their ending. They don't have to give me an ending. They don't owe me that. I chose to have children. Okay. I chose to bring them here. Now, my daughter hates for me to say this because she's on it, but she said, Mom, that's all right. Your wheelchair is going to have diamond spokes. It'll be all right. But we have to ourselves take the responsibility for setting up our finances, our powers of attorney for healthcare, our letting people know what we want so they don't have to fight. So that chapter in The Doctor is In on Prepare to Care is the template for how you set it up for your last years, how you want it. The other thing really working on now is the 330 years of life and the third 30 years, because when you retire, you may have a 30-year life expectancy.
Absolutely.
Today. What you gonna do?
Right.
What are you gonna do?
Right.
So I just started Krav Maga lessons. It's an Israeli martial art. I'm writing women's fiction under the name Taria Robbins. It's love stories for women who thought it was too late to believe. And that's on Amazon too. It links to my website. I'm thinking about becoming a licensed massage therapist. Life does not stop.
Life does not stop. Knowing that that's an optimistic note, knowing that there are things, we don't have to be passive about aging, know, and we don't have to feel that we're selfish if we take time for ourselves as caregivers.
You are protecting their most important resource.
That's right. If the well is dry, that's right. Absolutely. And if we need more information, we can go to your website and get your books.
Thank you very much.
Thank you. It was a pleasure.